In 1997, Steve Jobs and Apple asked us to think different. Our next speaker, Dr. Clay Johnston, was listening. Dr. Johnston, a graduate of Amherst College and Harvard Medical School and former professor and vice chair of neurology at UC San Francisco, examines every issue critically. Among his nearly 400 publications are investigations of where individuals with stroke should receive care, what interventions are of greatest value in health, and what are the best therapies for stroke. However, no issue is safe from Dr. Johnston's critical eye, whether it is a century-old neurological sign, funding for the NIH, or even the design of hospital gowns. Because he thinks different, Dr. Johnston in 2014 was selected as the inaugural dean of the Dell Medical School at the University of Texas at Austin. In 73 days, he will welcome the first class of medical students to UT Austin, where he is rethinking everything. Today we welcome him as a keynote speaker at the d.health Summit. Clay.
I'm over here, Ray. Yeah, thank you. Thanks. It's a great pleasure to be here. Thanks, Ray, for that introduction, which is just a little bit embarrassing, but I appreciate it. We're fellow neurologists too, so we've known each other for a long time, and Ray's work has really been some of the only great work in neurology to think about how to change the system of care, how to fundamentally change the way we treat patients. So great to be a part of this. And this group has had the discussion this morning has been really terrific. I think we all kind of know what the problems are. So I'm going to click through the problems and then spend a little more time about over what we see as this unique opportunity creating a med school now. What should we do? And leave, I hope, plenty of time for questions to get your feedback, too, on, okay, that doesn't make sense, or you should do this instead, or whatever, which I'm also happy to do during the break. Moore's Law. So this is just cost per transistor dramatically decreased over time. Change in every industry, right? And, of course, we're, 19% of GDP now? And this would kind of represent the technology and its representation in the healthcare space. I mean, as all of us are saying, what happened? Even email, hardly a technology, hasn't really been embraced as part of the healthcare system. So the healthcare system is clearly quite broken, the whole health system, and costs of care, of course, have gone up, and we've all been talking about that. Life expectancy, we talked about this 15-year gain in life expectancy. Most of that happened before the escalation in healthcare really occurred, right? So it is not because healthcare has produced greater longevity. It probably has a lot more to do with the social determinants of health and us tackling those earlier on in the century and now reaping the rewards for that. But that's almost a flat line anyway. And for white women, in middle-aged white women, it's gone down, right? So this is the first year where that's ever happened for any demographic group, and it did for white women. The life expectancy went down by a month. So huge investment and very little return. Of course, most of that investment on health care and not on health, right? So that's part of what we're talking about. And you all know this. We are by far number one. Sweden's well below us. Switzerland's number two. Norway sometimes, but we're 30% more expensive than Switzerland, and 34th by WHO's assessments of health outcomes. And that, I think, 34th, you kind of, okay, that doesn't sound so bad, right? But that puts us between Cuba and Costa Rica, which I think isn't so good, right? I mean, Cuba spends about an 11th of what we do on health and health care. And they have similar, life expectancy, birth or deaths at birth, all of that we do. Where's that money going? I mean, that's a pretty remarkable disconnect. I usually give 10 examples that I think are just like motivational for me to say, wow, this really does suck. But I'm only going to give you 3 because you all have been giving them anyway, and some of them actually are I kept taking them out as I was hearing people talk about them. One I left in because everybody's talked about it. No one pays for prevention, so everybody's talking about this. This is definitely true. Our models undervalue prevention, even when it has a saving benefit downstream. No one reminds you to take your meds. So this one's just so obvious, right? So the number one reason meds don't work isn't because we don't have good meds. It's because people don't take them. And that's actually 50% of people at 3 months. 50% of people aren't taking their meds as directed at 3 months. So that's a huge problem. But even just like a little app or a pharmacy record that comes back to the doctor's office or any kind of little thing to encourage that, it just doesn't happen. The physicians don't even feel like it's necessarily their responsibility to do it. And then this one's the one Ray was referring to. So hospital gowns or exposure rear. So the reason I think this one's relevant is there is no purpose for the hospital gown. Doctors don't like hospital gowns. Those things, if you want to examine a patient, you generally want to examine them from the front. Nurses don't like hospital gowns. They spend a lot more time covering up patients than they do wanting to uncover them, right? And patients hate them, right? And if you've ever had to wear one, you know how dehumanizing it is to be in a hospital gown. The hospital gown goes back at least 100 years. We were trying to find out who invented the thing and where it came from. We can't find that history. If anybody knows it, please tell me. And it's ubiquitous. It's not just in the U.S. healthcare system. It's across the world, this hospital gown. Oh, you got rid of it. Okay, good. Well, it's not quite ubiquitous then. But the reality is that we've let that thing stay for over 100 years. Nobody likes it, and it's just in our system. Right? What is that? Tradition? Is it a lack of insight and a lack of being person-centered, human-centered in our design? So anyway, that's why I like that example. I think for me, it's like, wow, we are so off base. So the healthcare delivery system obviously broken, highly invested in the status quo, and of course fee-for-service pushes us to do more rather than to do better, and lots of examples of where that's happening, and then treating the sickest, of course, instead of promoting health. And then it's no surprise if technologies actually reduce the need for a doctor visit or reduce the need for an OR use or an MRI scan or whatever, then why would we accept that on the provider side, right? Why would we want that on the provider side? Because we get paid for the OR visit, the OR, the ER visit, all this. That's where the money comes from. So in fact, so no surprise, and then of course providers resist these kinds of changes. It's inherent in our fee-for-service system. And then I would argue that the community health system is broken as well. We focus a lot on doctors and their tools, so drugs, devices, and all that, spend a ton of money on that. We're now starting to talk a little bit more about systems of care, and I would include in that telehealth and how we use nurses and pharmacists. But the real opportunity is actually going out in the community and thinking about, well, how do we encourage better behaviors, with better outcomes that actually can reduce cost out in the community? How do we value that? But there are two problems with it. One is we've so undervalued it, we've required philanthropy and the public health system to come in and deal with that. Well, those are the first things that suffer in a recession, right? So we always underfund our philanthropies, and just they're based on altruistic goals, not on potential financial and economic consequences of successful entities. And then public health entities are the easiest to cut. Cutting, this happened in San Francisco over and over again when I was there, where they'd look at the budget, there'd be problems with the budget, and it would always be, the hospital would always play it this way too. Okay, we can cut the AIDS ward, that's fine, yeah, we'll do it, we'll cut the AIDS ward. You want to cut our budget. But then, so they would win. We couldn't cut the AIDS ward and its support, and what would get cut would be the public health interventions that actually probably downstream would have a greater impact on the health of the community. And that happens over and over again. New York is exceptional in its support of public health, but for most of us across the country, that support is very, very limited. The other problem is data. So IBM sort of smart city thing, well, that was, fire, police, electricity, water, all that stuff. It wasn't about health. And so even doing a simple study, this is one that was done in San Francisco over a decade ago now, to say, okay, what are the major premature causes of death in San Francisco? It was a study that got published to do that. And this is what we found back then. So HIV/AIDS was number one for women. Never would have guessed that before doing the study. For men, you probably would have at that time. Remember, drugs were starting to work well. We were starting to get an idea about how to make that work, but never would you have guessed that for women. And then for men, it was violence and assaults, which we wouldn't have even necessarily considered a health issue. But as a major cause of premature death, that is a health issue. That's a major one. So this study, which was done as a snapshot, has had major implications in how the city then allocated resources to think about health. But it shouldn't have been a snapshot. It shouldn't have required a study. This is fundamental to the health, the whole fabric of the city. And yet we weren't geared up to even know what the key health issues were for the city at the time. And nothing's really changed. They haven't repeated this study in the last decade. And we all have our own mortality data, but getting down deeper to really understand it and what the premature causes are is a little harder. At this point, it's already been made this morning that the research system is really quite broken today. We put a wall between research and care. So this is research. This is care. The people who do care don't pay for research, don't pay for innovation cycles. They wait until somebody else does that work for them. And research is this special thing that requires government funding, right? It doesn't come from the healthcare system. And you have to go through grant cycles and all that, IRBs, lots of barriers. And so what you end up with is something that looks like Napoleon's march to Moscow. So the troops at the border, that broad band, and then the troops getting to Moscow is a smaller band, and the black line is the retreating army, which is almost none. And this is kind of where we are with the research process. So we've got now current funding lines are 9%. So 9% of people who apply for grants actually get them. And then only a small fraction of those actually have important results, and only a small fraction of those actually ultimately change health. And these cycle times, as was mentioned this morning, it depends on whose estimate you want to use, but they're 10 to 15 years. So 10 to 15 years cycle times to get data that would have the potential to change health. So, and this, by the way, that's for general research like clinical trials and all that. But for the kinds of stuff that we're talking about here, there's almost no source of funding for that. I mean, PCORI, some of you have some PCORI money. PCORI it's like a tenth of an average NIH institute. AHRQ, it's about a tenth of an average funding for NIH institute. And those other institutes generally don't fund this stuff, or at least not very well. And so the pool for the stuff at the systems of care, innovations in care, that pool of funding is tiny. So this is a very broken system. Academic medicine, this is my picture of academic medicine. It's very, very entrenched. It knows how to make this kind of system work. And it has a lot of trouble thinking about how not to be a part of the system in a lot of different ways. And we can talk about it, but just in fee-for-service, academic medicine has benefited more from fee-for-service than just about any other organizations in the U.S. They're very good at pricing, and they capture the conditions that generate the highest margins. And so they love fee-for-service medicine, whether their white papers say something different or whether their propaganda says something different. The reality is their foundation is built on fee-for-service medicine. And it's required to underwrite losses from research and education that are inherent in our system. So, average underwriting for research now is an extra 50 cents for every dollar you bring in that has to come from philanthropy or profits from other systems. And education is even worse. So for many places, it's over 50% subsidy required. So we have a new school, and it's a great position to be in to think about. Okay, well, that's what academic medicine's been. Okay, we have this really unique opportunity to do something different. Let's not blow it. What should we do? And ours is especially interesting because the people of the county that Austin sits in voted to increase their property tax in order for the school to exist. And happened at the tail end of, and this is Texas, remember, but it is Austin. Happened at the tail end of a recession, and you see it on your property tax bill. And it comes to the med school, provides us pretty decent core funding annually that we get. And UT never had a med school in Austin, even though it's the big university there. And Austin was the largest city without a med school. So that all this stuff, and Austin's a nice entrepreneurial city. So having all that confluence of events happen there gives us a really unique opportunity. And so for us, the question isn't, we can't ask the question, okay, how do we become a great med school? Because then we're failed from the start, right? If we're internally focused and we're not recognizing what our role should be in solving these problems. So our question is, can we create a better ecosystem for health innovation? Because the key is that the system should be able to fix itself. It should allow that these innovations can come through, and yeah, there'll be regulation, and I mean, all those things can happen. But there's regulation in the financial system, and our financial data is shared up there all the time, right? I mean, your credit score, that's, wow. They got a lot of my data that they're sharing and generate that credit score. So, all that has been able to be overcome in other industries. So this has something to do about how we can accelerate and promote innovation in the health space, not necessarily the health care space alone, but health, how we promote health and take that on as a key value of society. So one of the things we have to do is figure out how to copy the lean startup model. And I'll get to this a little bit, but if I don't have time to get into it in depth of how we're thinking about this. But we have to be able to launch innovations that we think are going to improve outcomes, evaluate them, tear them down if they're not working, build them up and scale them if they are. And we ought to do that with money that we use to provide healthcare delivery. Because every other industry does this, right? So we should be able to do that as well. So overall, that needs to be fundamental. And then what do we need to do to make this ecosystem work? And yeah, by the way, our vision statement for the school is a vital, inclusive health ecosystem. That's what we decided to have as our vision, which I realize is totally wacky. There's no other school that has a vision statement that's like that. But it's real. This is what we're trying to do. So we have to make the product value. Cost is just as important as quality and outcomes. If we don't accept that, then we won't get anything done. This isn't about increasing handouts or asking for more money from taxation. It's about reallocating wasted dollars, and this point was already made this morning very well, and taking that waste and putting it into something much more useful from society's perspective. We have to then be able to measure value, which I'm going to get to in a minute. I think that's a key problem that we're going to all face with the innovations that we want to see happen. And then it has to be embraced by our culture. And this is complicated. The providers have to embrace it. We went through some exercises to do this at UCSF. Very complicated to get them. At first they would, it sounds so simple, but they didn't think that they should ever include and think about cost. That somehow that undermine the trust between the doctor and the patient. And then we can go through how we kind of got them out of that. But that's a non-starter. You have to understand that wasting a patient's resources is not in their best interest. And that actually doing things that aren't absolutely indicated lead to more complications and worse outcomes for patients. And so now that dialogue's come along quite a bit, but it's not universally understood. The incentives we have to get right, and this is complicated and requires a change in thinking about how the system is organized. And then we have to have a way in which it's not top-down ideas being implemented, but the ideas can arise from the community, from a larger community. So Kaiser's had everything nicely aligned for decades, right? And Kaiser is a great health system, but why isn't it even better? Why is it that video visits are not a part of Kaiser? It's amazing when you think about it. They've had a great chance to do a lot more, and they haven't. Probably because it's top down. It's too top down. It hasn't allowed its own people to test and evaluate different kinds of innovations all at once. Scaling has to be possible. Wherever you make the initial investments, you are less likely to make back the investment in that local area. It's when you scale that you have that opportunity. So that has to be built into any innovation system. And then again, innovation has to be built into the funding model. So it has to be that this is a core function of healthcare. It is not a government function that then healthcare can either accept or not accept. It has to be driven by healthcare and the needs of the healthcare system. So for us then, the laboratory becomes Austin, right? So how do we make Austin a model healthy city? Model into is being model health, but also a model for how you can organize a health in an ecosystem to enable all of these things to occur and to advance health forward. So more practically, and then I don't get into this too deeply in this talk, but I'm going to finish early so we can, if there are questions about it, I'm happy to address it. But we have to create the funding streams. That's fundamentally, in the US, that's a critical problem. So if you've got a great innovation that enhances value, who's going to pay for that thing? And as we heard, that is a major problem. That was one of the last on the last panel. That was, well, two of them actually had single words about barriers that related to this. So for us, we can't go to people and ask them, well, what is it that you want? Well, we can do that, and we do that to some extent. And for us, it's the IDEO group. We had a couple guys quit IDEO and come and work for us and create the Design Institute for Health. But but it's who represents them and their interests best, and it's the payers. And the insurance companies are not necessarily doing that very well. So it's going directly to payers and saying, okay, what are your major problems? If we create a solution that lowers your cost and improves your outcomes, will you buy it? And then that becomes the sort of nugget of innovation that we then try to create. It's like the Michael Porter, Elizabeth Teisberg integrated practice unit, but not limited to that. It can be any kind of health innovation that could be sold to a payer as a special unit where the ROI is accessible within that unit of activity. So it could be a bundle, could be, there are all kinds of other approaches that are being taken. And this means we don't have to worry about, we have to take all the risk, or we have to create a big ACO, or we have to hire a bunch of physicians. We just solve these verticals by the priorities of the payers on their terms and move from one to the next. And then think about, again, dissemination in each of these. The entities that are currently in the payers, so for us, we have a county health district. They pay for indigent care in Travis County. They're a great group, and they have fixed dollars. They want to spend them better. But CMS, we have been trying to get CMS to change the way it uses its Disrupt 1115 waiver funds. Texas has a huge amount of Disrupt funding. It's meant for these kind of innovative projects, but the way it was set up, it's too rigid. So we're trying to get permission to create a kind of pool to move more quickly. And then self-insured businesses have been very interested in doing this as well. The partners is a critical piece. And so some of the innovations about, okay, do you commoditize doctors so that then you can plug them in to a system? That becomes highly relevant in these sorts of models, because we're not interested in owning all these. That's not a scalable model. The ownership model doesn't work. So we don't want to own those doctors. We'd rather figure out the models in which they can be engaged and their incentives recognized and rewarded. Absolutely have to have better data. So this is a huge challenge, and we're hoping to find the partner that'll make the cloud work, whether it's through conduits and the data doesn't actually sit in the cloud, that's the Cisco approach, or whether it's an actual cloud, that's the IBM approach. We don't know, but finding that partner to do this on a countywide basis, because ultimately we'll have that, right? In the U.S., it's so obvious it's going to happen. But if we can get there early, that becomes a critical part of the laboratory that will help us all. And then obviously, I'm telling you almost nothing about education, but for the physicians, we're at least complicit in getting us to this point, right? And physicians are often the most resistant to the changes that happen in these areas. So for us, that means we need to think about what the physicians of the future need to look like. Our physicians don't need to look like every physician that's trained out there, but we feel like that leadership and communication, entrepreneurism, human-centered design, creativity, those are core functions that are missing in the fabric of the physician community, and that we need to bring that into our curriculum. So our curriculum actually built around that notion. So how do we fit, or what's the big vision of where we fit? So traditionally, you got people working through governments and in companies through their insurance, and then getting care at community hospitals, and then academic hospitals sort of competing against them. I call it the fortress model. You hire a bunch of docs, and you have a bunch of clinics and hospitals, and you compete against everybody else, and you just control and care about what happens within your facilities with your docs. So that's pretty much the model, right? That's what exists pretty much everywhere. So our notion is we need to elevate the community partners. There are a bunch of them, nonprofits and public health entities, and make them real partners in delivering health, and potentially pay them for their success, not pay them on the backs, the whatever's left over in the budget at the end of the year, or based on philanthropy. And then our function, we don't need to own hospitals. The more we own hospitals and docs, the more entrenched we become in the current system, the harder it is for us to move. And the other issue is it distracts us. What do you want from academic medicine, right? You want your thought leaders to be aggregated there. So if you've got some thought leaders there, but 95% of them are just seeing patients, all day, all week, that's not a thought leadership plan. That is a factory of healthcare. And as much as you're focused on your factory, you're not focused on the innovation forefront, and that is a problem. So for us, it's more about how do we work with the existing hospitals, preferentially without boundaries. We have some limitations in our local environment how we can do this, but not owning them, not owning the docs, and working with them. And the same for the public health entities. They need help too. They need to understand the impact of what they're doing on health consequences in the averted cost downstream. As one example, they need to understand how to plug into the healthcare system. The education needs to change with some, like community health workers, for example, which we think could be much more active. But also, there's a role in translating people into into the plans that they receive from government and employers, and also into what insurance looks like, what it really means, not just negotiating for lower pricing, but getting what we want out of it, which is better health. So really, it's about us being in academic medicine, kind of in an innovation layer. So you can't just point and, that's where you go and you get your, that it's more about facilitating, providing the thought leadership and the coordination to encourage the innovation across that ecosystem without necessarily owning components. Now, we may need to own little places where we can be particularly out there, right? And I'm happy to talk about that, but that's not our strategy to own a bunch of stuff. And then what we're really doing is we don't think that the ideas are going to come from academia. I mean, some may, and we hope more do than currently, but we think it's really from a larger entrepreneurial community, whether social entrepreneurs, real entrepreneurs, or academic entrepreneurs, and in that we really should be enabling them to provide the solutions. So our function changes. It's a platform play where we enable the entrepreneurs to find somebody to sell their wares to prove that they're useful, and to get paid based on the benefits to society. That's going to require some partnership, because often the entrepreneurs don't really understand what's necessary or what we need right now in the healthcare system, and are coming from more of an engineering background. Hopefully that'll improve over time, but that's definitely a risk. So then it's about having entrepreneurs everywhere working on the problem. And this is how innovation works in every other area, right? We allow entrepreneurs to flourish. We just have resisted all of that in healthcare. And ultimately the play is to liberate entrepreneurs. So that's what we're trying to do. I know it looks pretty different, but I think that as a group that clearly could benefit from some additional liberation, myself included, it feels like it's the right time, and we're in a good place to give this a go. So thank you very much.
Clay is getting a very difficult job. Running a medical school is a difficult challenge. You have to balance clinical care, teaching and research. Now you add entrepreneurship onto it. Oh my God. going to be difficult, but it has to be done, and there's a lot of experimentation going on. I really would like to thank the VNA group for their support, and we'll have a half an hour break, and the best is yet to come. Thank you very much.
Thanks.